and we have been educating fellow colleagues and nurses about opioid use disorders. This program is approved for one continuing education credit from the California Board of Nursing. It is a great pleasure tonight that I introduce Dr. Carolyn Baird. Dr. Baird is a former president of the International Nurses Society on Addictions. She has a great wealth of experience in providing care to patients with substance use disorders. Dr. Baird, we welcome you, and she is going to discuss the role of medication in the treatment of opioid use disorders. I'll turn it over to you, Dr. Baird.
Thank you, Al. Dr. Arundio, I have to be professional here tonight. And I welcome all of you to listen to what I have to say about the role of medication in the treatment of opiate use disorders. I have no disclosures to make. No one is paying me to be enthusiastic about this, which I am very enthusiastic about the role of medication. And our target audience is specifically nurses and nurses working in the field of addictions, but this is for anyone who wants to know more about how you use medications in treating opioid use disorders. And we will be talking about the American Society of Addiction Medicine's National Practice Guidelines, and these came out in May of this year, so they're brand new, and they specifically talk about things over and above what we would do in addiction treatment normally. And also we're going to talk about some of the common medications that are used and also the special populations that we have within our larger population. And as I said, this is focusing on the additional knowledge and skills that are needed in this particular area. Unfortunately, an average of 12% of people who use illicit drugs become dependent. And that's an interesting statistic to me because we're talking about a continuum of 10% to 50%, and the majority are down around under 15%. So cannabis, 10%, methamphetamine, 12%, but you can see that heroin, 50%, become dependent. And I think that explains why we have this huge opioid epidemic right now in this country and really globally. But we have 2 million people who meet criteria for opioid use disorders due to their prescription drug use, and we have 0.5 million who meet criteria because of heroin use. And that's growing. We've already had, back in 2011, the president say that we have a prescription drug abuse epidemic, and now we're talking about heroin use epidemic and an overdose epidemic. And that designation comes from the fact that we have a death rate to opioid overdoses that compares to the death rate from vehicle crashes. And I know I live in southwestern Pennsylvania. My county had 38 overdoses in the past week. 3 of those died, and a large number of people were saved because we have the availability of naloxone in this particular county. So that was fantastic. Unfortunately, society is seeing a cost of approximately $55 billion a year due to opioid misuse. So that's a large cost to society. ASAM would like to hear us call this addiction involving opioid use. And I know opioid use disorder is what we're used to from the DSM-5, but start thinking in terms of addiction involving opioid use. We know this is a neurological disease. It affects brain reward, motivation, memory, and related circuitry. It affects specific receptors in the brain. They sit on the opioid receptors in the brain and impact the neurotransmitter systems in the brain. So it makes sense if you think in terms of what's going on in your brain, what's going on with the neurotransmitters, that medications being used to treat this disorder would be very helpful. They have done a lot of research. It's been researched and it's documented that this is effective. And it's effective because it does address the withdrawal and the cravings that occur, and it doesn't create euphoria. So it kind of stabilizes the condition of your patients. Unfortunately, less than 30% of programs use medications. And when you think of in terms of research saying how effective it is, it's kind of sad for our clients or our patients to think that only 30% of the programs they're attending are using medications, and that within those programs, less than half of the patients that would be eligible actually receive medications. So I want you to think about a number of things, and think in terms of, we're talking about evidence-based treatment recommendations, and they support the use of medication. And there are now practice guidelines that exist, and they will assist all of us in working with our clients in managing their care and in making clinical decisions about what we should do for them. Remember that guidelines are only effective if they're followed as they're outlined. So don't change them up, because if you do, you're going to impact outcomes, and outcomes are also impacted by patients not understanding and not being able to adhere to the treatment that they're receiving. Recommendations are only recommendations, and we know that there are a lot of federal and state regulations out there. They supersede the guidelines. So within the guidelines, they talk about assessment and diagnosis. They talk about treatment options, treating opioid withdrawal, the medications, methadone, buprenorphine, and naltrexone, and what psychosocial treatment should be going on at the same time. The special populations that are included are pregnant women, individuals with pain, adolescents, individuals with co-occurring psychiatric disorders, and that's a big one because within an addiction treatment setting, probably 80 to 95% of the individuals have co-occurring psychiatric disorders, and also individuals in the criminal justice system. And then lastly, we'll talk a little bit about naloxone. There is one other thing that is included, and that is the need for research, and there's a whole section on that. I included a link to the guidelines on the reference slide, and you can go and look and see if you're interested in what research is going on. For assessment, with any good treatment program, a comprehensive assessment is the very first thing that you do. When you're dealing with a client or a patient who may have an opioid use disorder, it's really important to pay special attention to urgent or emergent medical or psychiatric issues, and get a complete history of opioid use. And that's any trends, any periods of sobriety, any overdoses, anything like that. Also, you want a history of other substance-related disorders, what other substances they may have used, and that includes tobacco. It's really important to know whether they're using tobacco or not. Physical exams should include the CBC, liver function, an EKG, and whether your female patients are pregnant or not. The EKGs are important because all of these medications impact the QT interval. So, you're going to want to make sure that you're watching that, and you want to have a baseline for any changes that might occur during treatment. And because this is really a biopsychosocial spiritual illness, it's important to get social and environmental factors evaluated also. Diagnosing our patients, they provide a history, and then we do a comprehensive assessment. And because of that mode of diagnosis, if someone's referred to you with a diagnosis, it's important to reassess them and confirm the diagnosis. So don't take it on faith, reaffirm the diagnosis. Always watch for withdrawal symptoms and make sure you measure them with validated clinical scales. And I've given you 3 there that are really easy to download. They're available online. They don't have any cost to downloading them, so they can be used readily. You're going to use a urine drug screen while you're working with the client, so you want a baseline for urine drug screen, and then you're going to repeat it during treatment. And regulations for the OTPs say that they have to have 8 a year, and we always give that nice little caveat. You don't stick to your 8 a year, you look at your patient's stability, you look at the type and the setting of treatment, and you gauge when they're needed, and you can do them all the time. Treatment options are something that we always think in terms of being in an OTP or an OBOT, but ASAM gives 4 levels for treatment, 1 being the general outpatient, 2 being your IOP or partial, you have a residential setting, and you have the inpatient or hospital setting. It's really appropriate for MAT to be used in any of those settings. And how do you decide that? Well, one thing that you're going to do is do your assessment and determine what you think would be the appropriate setting, and then you're going to have shared decision making with the clients. And you're going to look at any preferences that they have, look at past treatment history. A past treatment history might indicate that they do better in one setting rather than in another setting. And also look at things like supervision, and the daily supervision is available in an OTP, weekly or monthly is in an OBOT, and does your client need a weekly, a daily, what's going to do best for that individual patient? If the patient has trouble adhering, you're going to monitor and evaluate that adherence level. You may need to change the venue depending on whether or not your patient needs more or less supervision. Medication is often used only to treat withdrawal. And when medication is used for withdrawal management, as a standalone, it is not treatment. So be aware that that carries a much more of a safety concern and a risk of relapse. So while in one hand it decreases the risk of the individual developing strong cravings, it also increases any safety concerns that you might have for them. Methadone is one that is used for treating the withdrawal. If you're using methadone, it should be used in an OTP or an inpatient setting. Short-acting opiates, you begin with 20 to 30 milligrams per day, and they can be tapered, and the taper completed in 6 to 10 days. If you're using buprenorphine as part of your opioid withdrawal process, and for a short-acting opiate, you're going to wait 12 to 18 hours past that last dose. If you have a long-acting, you're going to wait 24 to 48 hours. And then the individual is going to be dosed to suppress their withdrawal symptoms. And that could be 4 to 16 milligrams per day. A tapering schedule could be as short as 3 to 5 days with, say, your short-acting, maybe as long as 30 days or more with the longer-acting. Now, there is some research that is being done on using buprenorphine plus low-dose oral naltrexone to manage the withdrawal, and that would then facilitate using long-acting injectable naltrexone. The research is not in on that. It's just mentioned. It's not recommended at this point in time. So just kind of watch for that research and see how they're coming with that. For some time now, clonidine has been used off-label, and it's used to manage the withdrawal symptoms. So it can be taken orally or it can be taken transdermally, but it would be a dose of 1 to 3 milligrams every 6 to 8 hours. The limit on that would be a total of 1.2 milligrams per day. And as I said, that's off-label. It's been used, though, for quite a while in that manner. Usually, when we talk about medication-assisted treatment, we're talking about the use of methadone, buprenorphine, or naltrexone. And methadone is the big granddaddy for medication-assisted treatment. It's been a treatment option since 1965. It's actually been used for pregnancy since 1975, so it's pretty much an accepted mode of treatment for a long time now. Your patient picture is going to be somebody who is physiologically dependent, they're able to give informed consent, and there are no contraindications that you've seen from their assessment. When we talk about contraindications, it might be that somebody has a very long QT interval when you do their assessment and you do their EKG. That might be a contraindication, and you would want to at least think about it before you started them. When someone starts on methadone, their initial dose range is from 10 to 30 milligrams. In that first day, you can reassess them in 3 to 4 hours and see if they have persistent withdrawal symptoms, and then you may give them a second dose of up to 10 milligrams to, settle that down. Usually, you're going to see people have a dosage of 60 to 120 milligrams. And you will get there with small increment increases of 5 to 10 milligrams a day, but you're not going to increase them less than 7 days apart. And if you stop and think about the half-life of methadone being 24 hours, someone who takes 30 milligrams a day for approximately 5 days will already be up to 60 milligrams. And that's why you want to wait 7 days, see what it stabilizes out to, before you then give a small amount more to start increasing it. The administration of methadone is usually a supervised dosage every day, and that's done to prevent misuse and diversion. You really want to get somebody started on it, observe them taking it, and make sure that they're stabilizing. And we do get to a point where they have non-monitored dosing with take-home doses. That's going to be based on patients' clinical response and behavior. There are also 8 criteria that are listed in the regulations, the federal regulations for take-home doses for methadone. So we already have a scale to kind of guide it by. There's always psychosocial treatment that is included with medication-assisted treatment. So you'll see a common theme that I will mention this every time I talk about the particular drug. And it's just that the research basically says that medication and the talk therapy, as they want to call it, psychotherapy, psychosocial treatment, should be a dual approach to this. In methadone treatment, one of the things that could be really focused on is relapse prevention. Sometimes people taper off of their methadone, and sometimes they just leave treatment. If someone relapses once they're no longer in treatment, the MAT should be restarted. Sometimes people have problems with methadone. They have side effects that really make it uncomfortable for them. They can't attain or maintain treatment goals. They can't stay in treatment because they consider the side effects so intolerable. We now have an option for people because we now have buprenorphine and naltrexone as other medications. So if you're looking at someone who's on methadone and has decided to go to buprenorphine, it's really easy to do. First, you have to get them down, tapered down to 30 or 40 milligrams per day Less is better, but you can do the switch at 30 to 40 milligrams. You can take someone on methadone to oral or extended release injectable naltrexone very easily. Um, they can be completely withdrawn or participating in a naltrexone facilitated opioid withdrawal. It's really easy to take them down. Always warn people of risks. If someone's on a replacement opioid like methadone, buprenorphine, they're being treated with MAT and they stop using it, they have a very increased risk of death and opioid overdose. So it's important that they know the risks of doing that. Buprenorphine is the second medication that is used in medication-assisted treatment. The first dose is usually 2 to 4 milligrams. It's given after the individual is showing signs of mild to moderate withdrawal. And their increases are in increments of 2 to 4 milligrams. The average dose with buprenorphine is approximately 8 milligrams per day. If opioid use continues, increase by 4 to 8 milligrams per day up to the 12 or 16 or even higher. And we do the same with methadone. Someone who gets to the higher doses and is still using, typically they need to be increased. That's one of the things about any of the medication-assisted treatment, that if someone continues to use, the dose isn't high enough, and they need to be, the dose needs to be raised until they get to the point where they've stopped using. The FDA has set a limit on 24 milligrams per day, and there is some evidence that higher doses lose effectiveness and increase diversion potential. So, when you're thinking in terms of, whether or not to increase somebody because, you're getting patient reports of withdrawal or craving or, discomfort, that there is the limited evidence out there that medication does lose its effectiveness in the higher doses. Induction for buprenorphine is usually observed, but there is some research that supports they can have a home induction. We really encourage that only experienced patients and prescribers do home induction. Frequent office visits, weekly at first, to gauge response and to reduce diversion are recommended when people are starting buprenorphine. You do urine drug screens just like you do for methadone, and you're testing for the buprenorphine, the metabolites, other substances, and any prescription drugs. And here's my psychosocial treatment. Remember, psychosocial treatment is always hand in hand with medication-assisted treatment. Don't forget to check on the prescription drug monitoring program for anything else that the individual might be taking, and particularly, in terms of individuals being having co-occurring psychiatric disorders. You can check for medication that they have been given by their doctor to manage anxiety and be aware of that. Recall visits are very used frequently for pill counts to make sure that individuals actually, and now with the strips, that individuals aren't selling them, that they are actually taking them. There's no recommended time limit, and I put this in here because I'm hearing from some of the clients that I work with in my private practice that they're being told that buprenorphine can only be used for 18 months. And so they've been told that they will be tapered off and put out of their programs. So want to reinforce that the research isn't saying that there's a recommended time limit. There's nothing right now that says individuals need to be taken off of it. If it is discontinued, it's a slow process. over several months. And remember that if someone discontinues treatment and they resume opioid use, that increases their risk of overdose and death. And so it's really important if you're discontinuing it that and you're tapering them down, that you monitor very closely, and then you continue to monitor and work with that individual after they're no longer taking the medication. If someone is on buprenorphine and they decide that they want to go to naltrexone, then they have to have 7 to 14 days between their last dose of buprenorphine and the first dose that they're going to get of the naltrexone. If someone wants to go from buprenorphine to methadone, there's no delay. You're talking about going from a partial to a full agonist. There's no adverse reaction if they do that. So they don't have to be tapered off. They can just be moved from buprenorphine to methadone. Naltrexone is very effective for preventing relapse. It's one has a recommendation for it. The oral is something that can be used where you really want to be able to observe, supervise, and you're concerned about somebody adhering to it. They don't have to be on methadone or buprenorphine. They can be on an oral. They would take daily 50 milligram doses, or they could take it 3 times a week. They would have 100 milligrams, 100 milligrams, and 150 milligrams spaced out across the week. If they were on the extended release injectable, they would get it every 4 weeks. It would be a deep intramuscular in the gluteal muscle, and it would be 380 milligrams in their dose. Again, the research says that there is nothing to support just having naltrexone. There should be concurrent psychosocial treatment going on at the same time. There's no recommended length of treatment for naltrexone. And really, when you're trying to decide between the 3 medications, should someone choose methadone? Should they choose buprenorphine? Should they choose naltrexone? It really is a part of patient circumstances when you're looking at your clinical judgment for which one to choose. What's best for the client? What fits the client's lifestyle the best? The nice thing about naltrexone, it can be stopped abruptly with no withdrawal. Unfortunately, one of the things that we're seeing is that if someone stops it abruptly and resumes use, they overdose pretty quickly. And we've also seen that individuals who are, maybe a day or 2 before their shot and use, they can overdose. So it's all very touchy around the next dose timing. If you're going from naltrexone to buprenorphine or methadone, you have to plan it, you have to consider it, you have to monitor it. It's a little trickier to go from naltrexone to buprenorphine or methadone. There's no physical dependence with an antagonist. It's not going to precipitate a withdrawal, but you need to lower the naltrexone level, and you're going to have a day for the oral, but you're going to have to wait a month on the injectable, and the initial doses are going to have to be low. And discontinuing, as I said, the antagonist and resuming opioid use has increased risk of death and the risk of overdose and death. I made you a nice little table because I always like to visualize things like this. And so it's just a comparison of the 3 medications. We can see that their action is methadone's a full agonist, buprenorphine is a partial agonist, and naltrexone is an antagonist. They're all available in oral, but the naltrexone is also available as a long-acting injectable. You can take all of them daily, but you can also take naltrexone 3 times a week or a one time a month injection. We're going to talk about pregnancy a little bit later, but I wanted to stick it on the table because methadone works very, very well in pregnancy. As I said, it's been recommended for use in pregnancy since 1975. You can use buprenorphine. There's research, ongoing research, and it's not coming up with anything negative, but you can only use the mono product. You can't use Suboxone. And naltrexone is not recommended at all for use during pregnancy. What I think is really kind of eye-opening is that a dose of methadone is $1 a day. That's $30 a month. A dose of buprenorphine can be anywhere from $4 to $30 a day. And if you figure that out, that's anywhere from $120 a month to $900 a month. And naltrexone is also $700 to $1,000 per that monthly dose. And I didn't figure out, I didn't get a cost on the daily or the 3 times a week, but if you're doing the long-acting injectable, that injection is $70 to $1,000 for that dose. So that's just kind of interesting when you look at it that way. We always think in terms of naltrexone being the very most expensive choice, but if you're paying $30 a dose for buprenorphine, you're at $900. So. And as we said, the psychosocial treatment is highly recommended. That's what it says. That's what we should be doing. And that includes an assessment, supportive counseling, links to family supports. And that's we always talk in terms of, are we doing family therapy with our clients? We should be doing family therapy. And when we talk about family supports, a family for one of your patients can be almost anything, and we know that. It doesn't have to be the family they were born into. It can be the people they live with in their living arrangement. It can be the group that they're with at their meetings. It's important to find out who their family is. And always the referrals to community services, and we're always looking at that whole issue of doing a complete assessment of what their needs are, kind of recovery-oriented systems of care, linkage to everything that they need to have. So you have that whole treatment planning collaborative or the treatment team or whatever you want to call it. And with that group, look at, what all do they need, what type of treatment do they need, what intensity do they need, what parameters are you going to set around non-adherence, how are you going to link them up with everybody that they need linked up with. All of that kind of goes on with this treatment planning collaborative. So our special populations, we have 5 of them that we're going to talk about. We have pregnant women. And pregnant women, this is a population that can be in your treatment population already, and they come in one day and they tell you that they're pregnant. Or they can be someone who shows up for treatment and has just discovered that they're pregnant. And one of the things with pregnancy that we know is that frequently due to the lifestyle and everything that goes on with drug use, a lot of times women don't know they're pregnant, and sometimes in early stages, they're the way they feel may actually cause them to use more. So they really are not in particularly good shape when they come in. So it's important that you immediately ID any urgent and emergent medical conditions that they may have. You want to provide medical exam and psychosocial assessment, get the whole picture of what's going on. Make sure you test for HIV, for hepatitis B and C, look at their liver function. If someone has a negative hepatitis serology, offer them the vaccine, the A and B, and be aware that when someone comes in and they're new to treatment for you, they're probably new to their prenatal care, and often they're late in initiating prenatal care. So there are a lot of risks that go with that, a lot of complications to the pregnancy that go with that. Pregnancy of itself may interfere with them keeping their appointments. So they may have some missed appointments. They may have poor weight gain. They may demonstrate signs of intoxication and withdrawal even within the treatment setting. So you want to be aware of all of that. The, the way that medication is metabolized during pregnancy is very different. And so it's going to be important to be aware if someone's metabolizing it very rapidly that they may need an increase. Their gynecologists and obstetricians are going to need to be educated. That's one of the areas that's really touchy, is that often there's enough stigma being someone who's dealing with an addiction, but to be pregnant and have an addiction and be going to a gynecologist or an obstetrician who isn't particularly understanding, doesn't really understand opiate use disorders, doesn't understand treatment, it's very difficult. So educate them. Get releases signed so that the patients can be co-managed. And the earlier that the pharmacologic treatment can be started, the better. So get them started right away. And again, it's methadone or buprenorphine mono product that they can use. We usually encourage that someone be inpatient for induction, especially if it's later in pregnancy. We know with health insurance it's very difficult to do that, but the more ability that you have to monitor what's going on with the patient during induction, the better it is. So someone who is pregnant, they again should be started the same way, but they should be started on 20 to 30 milligrams with the 5 to 10 milligram increase after 3 to 6 hours for their withdrawal. And again, you use the same thing, increases of 5 to 10 milligrams a week to level out the withdrawal and to minimize craving. Remember, this is 24-hour half-life, so you don't want to increase too rapidly, so you're going to wait that week before you do the next increase. Be aware that advancing pregnancy affects drug metabolism. You have more fluid, more tissue, that decreases the plasma levels. There's also increased clearance. So all of those impact pregnancy. One of the things that the research is saying is that it's really important to split dose the individuals as their medications being increased to minimize the risk of withdrawal. The doses get higher, and that necessitates splitting them so someone isn't, over-sedated with that larger dose, and is just managed better. And something that I read just the other day was talking about the neonatal abstinence syndrome afterwards, and how it's not particularly associated with the dosage, more on maybe how it's managed. They did a study, and they had someone who was on 480 milligrams of methadone in split dose, and her infant had no neonatal abstinence syndrome. So, it's important that you be educated on that. And I won't talk about that here, but that's one of my special cares, is to let people think about in terms of what's best for the mother and the infant, and not worry so much about, you know, anything else. So once the infant is born, the dose gets adjusted, and it doesn't get terminated immediately upon delivery. This is the case where you want to taper it off. You want to judge by how the mom's feeling, what she needs. It's all very individual. Talk to your patient kind of thing. So during pregnancy, you're going to, again, provide the psychosocial counseling. You're going to discuss any implications of urine drug screen results. It's really important that you kind of hammer home the idea that you don't want to introduce any other drugs into, you know, the mom's system. You know, hammer home's not a nice term to use, but you all kind of understand what I mean when you know, motivate people to understand that this is what's best for mom and this is what's best for baby. And let's clear everything out. Let's deal with just keeping her solid and stable with the medication-assisted treatment for her opioid use. So naltrexone has risks if someone's pregnant. So if you have someone who's on naltrexone who becomes pregnant, then they really need to be encouraged to discontinue and go to one of the other drugs. And once, and they can discontinue it and not go on something else, but if they're in a situation where you're concerned that they might relapse, it's much better for them to switch to methadone or buprenorphine mono product than risk them not being on something and then relapsing. The naloxone is really not recommended in pregnancy. However, if you've got a life threat situation and this is something where you're concerned that you might lose mom, or, you know, if you lose mom, you're going to lose the baby, then you're probably going to at least consider it. And always encourage women who are on methadone to breastfeed. One of the things that the research says is that very small amounts of methadone are released in breast milk. It's not even dose related. You can't even say that at higher doses there's more and at lower doses there's less. There's a very small amount. It's not even enough that you would consider letting someone breastfeed so that the baby got the methadone for neonatal abstinence syndrome. That's how little is in the breast milk. So they should be encouraged to breastfeed. If you have someone with a chronic pain disorder, the first thing you're going to do is make sure you have a correct diagnosis and you have a target for treatment. And then the medications that you want to use are acetaminophen and the non-steroidal anti-inflammatories. If someone is on, and if someone has an untreated opioid use disorder, you would give them the opiate agonists. That would be a very good thing to use. And always the pharmacotherapy and psychosocial treatment together. If someone is on methadone already, they're in treatment for opiate use disorder with methadone, and they have pain or they develop pain, then they're going to be given additional opioids for acute pain and surgery. Think in terms of methadone has a 24-hour half-life. You don't want to put somebody on methadone around the clock. They might have their methadone in the morning, and then they would have a regular opioid, prescription opioid in between. And always think in terms of there's a lot of tolerance here, so higher doses of medication are recommended for somebody who's already in treatment. So someone who says, you know, they're already look like they're on a lot of medication and they say they're in pain, believe them and give the higher dose of medication. If someone's on buprenorphine and they have mild acute pain, just temporary increase of it, then you're just, you know, you're going to temporarily increase their buprenorphine. If somebody is on buprenorphine and has severe pain, then you discontinue it and you use a high-potency opioid. You're going to monitor them carefully. You're going to use regional anesthesia if necessary. If someone's on buprenorphine and has surgery, the surgeon and the anesthesiologist should consult. Potentially what you want to do is just continue it 24 to 36 hours ahead of the surgery. And then once they don't need any full agonist analgesia, then you would resume their buprenorphine. The response is not the same on naltrexone. And I know I do another training where I talk a little bit about naltrexone, and people always say, what do you do with someone who's on naltrexone and they're going to have surgery? So I have the answer here. If someone's on mild pain and they are on naltrexone, you give them a non-steroidal anti-inflammatory. If they have moderate to severe pain, you are going to give them ketorolac, which is Toradol, short-term. And if they're going to have surgery, they need to discontinue any oral naltrexone 72 hours prior to. If they're on the injectable 1 dose a month, then they need to discontinue it 30 days prior to surgery. Adolescents are always a group that we're worried about. They can be on methadone and these other medications under 18, but you have to observe federal law and obtain FDA approval. Consider both the agonist or the antagonist when you're considering it for them. They're going to need concurrent pharmacological and psychosocial treatment. Again, don't give them medication without giving them the psychosocial treatment. Make sure that you include education for them, particularly with this population. You really want to focus on sexual risk reduction and just look at comprehensive treatment all the way around. And this may be a population that would be better off in some type of specialized facility with multidimensional services for them. Co-occurring psychiatric disorders, as we said, there's probably 80 to 95% co-occurrence with these. They need to have the pharmacotherapy and their psychosocial treatment. You want to look at the severity of their symptomatology. You want to really pay attention to, are they suicidal? Are they homicidal? If they are, they need immediate intervention. You think reduction of risk. And while you're working with them, look at all their underlying factors. Make sure that they're being monitored and evaluated on an ongoing basis and that they receive follow-up. Look at the potential for drug-to-drug interactions because there's a lot of drug-to-drug interactions that come with psychoactive psychiatric medication and the other psychoactive meds to work with their addiction problem. If someone has co-occurring schizophrenia, they may actually need to be even more assertively treated in some type of county or some type of community program. Criminal justice, a lot of times people think in terms of, all right, they've been in jail for a period of time, they haven't had access to drugs, they can come out and they don't need to even, worry about thinking about going to any type of medication-assisted treatment. But this combination of pharmacotherapy and psychosocial treatment is very appropriate for prisoners and parolees. And length of sentence is not an issue. We don't think in terms of, well, somebody's been in for X number of years, they don't need it, but if they've been in for less than that, they do. They're appropriate for both the agonist and the antagonist, and evidence doesn't support one over the other. One thing that they do say is that treatment should be initiated at least 30 days prior to release. That means that then they're stable on their medication. And, it's hard enough to come out of a very structured, supervised situation like being incarcerated and be reintegrated into society. There are a lot of stressors included with that. and those are the type of stressors that cause people to relapse. So that's why we think in terms of it's really important to look at initiating treatment, having them stable, and allowing that to help them reintegrate back into their life. And naloxone, it should be given in event of overdose, and it can and should be given if the pregnant woman is in a life-threatening situation. If she's overdosed and she's going to die, it's better that you do that. It's not recommended. That's why we say mono product for buprenorphine. The consensus opinion is that patients and family members should be given prescriptions and trained in the use. All first responders, EMS, police, firefighters should be trained and authorized to use. I know in my state, the governor just did a blanket prescription for the availability of naloxone. Everybody can get it without having to go to a doctor. There are pharmacies that make it available. There are all kinds of programs. And like I said, we had 38 individuals overdose in the last week. And 3 of them died, but a lot more were saved through the intervention of naloxone. So this is the fun part now, because I'm giving you 3 cases, and I thought this was a fun way to kind of put it here. And we can look at the 30-year-old female who is pregnant. She has an MBA and has an executive position in a very high-stress job. So just think, she's probably what the financial officer or someone in some job, she uses heroin to manage her stress. And she's not married, so her family's very involved, and all they can think is they want her off of everything. They want her clean and sober for the baby's sake. So they're not going to want her on anything at all. The 35-year-old man, he's been incarcerated for 2 years, and while he's been in there, he's had no meds at all. He's going to be released on probation within 24 hours. He has a history of bipolar disorder with a back injury with chronic pain, and he was abusing prescription opiates prior to being incarcerated. And then we have the 21-year-old male who's a high school dropout. He started using heroin in his teens. He's had at least 1 overdose. He uses just about everything you could name, and he's getting through life just hanging out. So those are our cases. And after listening to this, what would you do? What would you put them on? Any questions? Are there any questions?
Carolyn, I can read your question here.
Yeah, I can't see them. I'm like
Yep,
pushing the button here, but not seeing any.
I can see him, so I'll throw it out to you. Can you give
Okay.
some statistics on success or abstinent rates regarding medication-assisted treatment effectiveness versus non-medication assisted treatment?
Do I have any off the top of my head? I don't have any off the top of my head. I know that there's a lot of research. There's a number of reviews that have been done, and they're really just starting to look at that because there's been a lot of stigma against it. So I'm looking at my sheet of notes about the systematic reviews that I found to see if one of them has anything on it. They're shading toward that it's more effective, and I think that's one of the areas that they have for further research. mostly,
I think
I
it's going
think
to
what
vary.
the, go ahead.
I think it's going to vary too by practice setting, and I think as we move more into recovery models where we're really monitoring outcomes more, I think we'll be able to get better data on that as well.
Yeah, most of the studies that I found when I was doing my reviews was that they're looking at which of the medications is more effective, which I thought was really interesting, rather than looking at um, was it more effective than not. I think they almost went with kind of a, it is more effective, but which one is better than the other kind of approach to it,
Yeah,
which I
yeah,
found kind of interesting.
that is interesting.
Yeah.
And then another question says regarding slide 24, I heard naloxone use with an opioid could precipitate withdrawal. Please comment.
Naloxone with, I mean, that's,
With
I'm not
using an
sure I
opioid,
understand the
using the
question.
two together. The question, like naloxone, if you use it simultaneously with an opioid, it could just maybe be the way the slide was listed, could precipitate withdrawal. Which I think you clarified that there's a window of like 7 to 14 days that a person has to be off an opioid before you put them on naloxone.
Oh, you're talking about naltrexone.
Yeah, yeah. I mean
Okay.
naltrexone. I'm sorry, I read
Okay.
naloxone. It's
Yeah, I
naltrexone.
was confused.
Sorry. Yeah,
Um,
I confused. It said I heard naltrexone use with an opioid could precipitate withdrawal.
when you, the naltrexone is the antagonist, so it
Right.
occupies the site. When you get in trouble is if you're close, like you're on it, you're getting your 30-day injections. If you use it like the day, and this is what they're saying, like you use it at day 28, your shot's due on day 30, then they can overdose. Is that the question?
Mm, Now, the way I'm understanding it, she also says, referring to slide 24, I heard naltrexone use with an opioid could precipitate withdrawal. Please comment.
Okay. No, it doesn't. There's no physical dependence. It doesn't precipitate withdrawal. That's the slide to put it up.
Right,
There's
okay.
no physical dependence with an antagonist.
Right, but if they were on an opioid, you wouldn't use the naltrexone because that could precipitate withdrawal.
Hmm.
I think that's what she's saying.
I don't know. That's not what I said, but that's okay.
Yeah.
There's no
And
physical
then,
dependence with an antagonist, so it's not going to precipitate withdrawal.
right.
So,
Again, in the next one, may I respectfully request as a suggestion that in any process, screening, treatment, recovery, etc., that counseling be a main part of the focus for these processes that supports and educates individuals seeking help for their disorder or for getting off of opioids. Your thoughts, please.
so the individual is suggesting that we only do counseling.
Um, re request as a suggestion that in any process, screening, treatment, recovery, that counseling just be a main part of the focus for these processes that supports and educates individuals seeking help for this disorder or for getting off of opioids. I think saying that, emphasizing the importance of counseling, but I don't see anything in the question not saying not to use medication assisted
Okay.
treatment.
Well, I think what I said was the research says that the psychosocial treatment, it has to go hand in hand with medication-assisted treatment.
Absolutely.
And I said that in the beginning, and I said that for each of the medications, and then there's a slide on it. So that's a big part of it. It's not, there's nothing at all in the research that says that medication by itself is treatment. I mean, and that's what I covered with the use of these medications to manage withdrawal. Standalone use of medication is not treatment. So anytime that someone's in a program, it's medication-assisted treatment, so it goes hand in hand with counseling, psychotherapy, psychosocial treatment, whatever you want to call it. I don't know if that answers the question.
Yeah, I think it does, and I think I think it's philosophy of treatment. I think individuals believe that people shouldn't be on any type of drug after they're detoxed, and then, we know that it's a brain disease, and we know there's changes to receptors, and a lot of individuals believe that medication-assisted treatment beyond detox, long-term therapy, like with use of buprenorphine or Suboxone, really, helps get the patient better, and better that they're using that in a monitored situation than abusing drugs off the street.
Right.
But so I think some of it's a matter of philosophy.
It is very much a matter of philosophy.
Yep, yep. This one, I'm not sure. It says nursing on Suboxone or Subutex safety. So I guess it says nursing on Suboxone or Subutex safety, I guess referring to nursing care.
Right. No, I did not include anything on nursing care in here. I specifically spoke about the role of medication in this type of treatment.
Okay. This question says, should teens and early 20s be discouraged from taking the Vivitrol shot due to their higher levels of accidents and inability to treat pain?
I would not say no. I mean, I think that if you're saying no, don't give it to them because they're highly predicted that they're going to need surgery and so will need to be taken off of it. To me, that's kind of a negative thing. I would say no, they could be on it, and if for some reason they would, need surgery, then follow the recommended guidelines for managing that. But I think there are ways to manage pain when someone is on naltrexone to the point where you wouldn't keep them from being on it because of their age and any risk factor that you're thinking they might have.
Okay. All right.
I'm hearing a lot coming out of the rehabs with, and I don't know if it's the particular rehabs in my area, but they seem to be having people detox and then be put on the Vivitrol shot. That seems to be right now the process that they're following.
Yes, you're seeing that in a lot of facilities. I agree.
Yeah.
Okay, next question. Is there available research on best practices management of active opioid users while in need of acute care?
Like when they say acute care.
Could be, and again, I'm just maybe reading into the question, but I'm thinking maybe like with pain management. I don't know.
Well, they cover that in the guidelines and encourage if someone's on the methadone that they can still have their methadone in the dose in the morning, have the shorter acting opiates through the day, the buprenorphine. They can have small increases, temporary increases in their buprenorphine. You know, the NSAIDs are used, Toradol's used. So is that, I don't know if that covers the question, but there are guidelines in there that cover the use with pain. If it's acute care for something else, I would think pain would be the one thing that you would need to worry about, was managing pain.
Right, I agree. Okay. This one says, regarding the initial assessment of the patient, you mentioned that the patient should have a CBC, liver functions, and an EKG. In my experience, these patients can't even afford the treatment they are requesting. Insurances are not reimbursing for opioid detox in a hospital setting, and it is very difficult to get reimbursement for residential treatment in general. And most patients don't even have insurance. So I agree that physical assessment is essential, but the labs are not always able to be obtained. And I guess that would be based on the patient's ability to pay and if their insurance covered it.
Yeah, it's sad. You know, I've traveled around the country doing a different training that I do, and recognize that there's a whole continuum of what's available in the states. With some states, their OTPs not having access to any type of primary care, and other states where facilities have a whole continuum of care in them. So I agree, sometimes it's very difficult.
Yeah. This question says, I treat a lot of pilots and nurses, and I find that Vivitrol seems to work very well with people who have a license to lose. I also find that for everyone else, meaning non-professionals, extended use of Suboxone has a fairly low success rate. Can you comment on this?
Well, I think that I have to agree that the naltrexone is viewed very differently from methadone and Suboxone in terms of someone who's working with some type of licensing. And I know that they've done studies looking at whether or not there's cognitive function loss with methadone and buprenorphine. How that translates to the effectiveness of buprenorphine long term. I mean, I can agree that naltrexone for a professional and for someone who's dealing with a licensing board, they're much more receptive to the naltrexone, and they're much more, they're a better candidate for it because they're very highly motivated. They may not need the structure and the supervision for medication. Someone who's on buprenorphine who isn't very motivated may be failing because they don't have the higher level of supervision that they need. I don't know. I mean, there's a whole connection between adhering to treatment and success rates. So someone who's highly motivated and adheres to their treatment regime does better overall than someone who isn't motivated and doesn't adhere well.
Yeah. Now, this is just a comment. Naloxone is not absorbed orally. Naltrexone is absorbed and can precipitate withdrawal if a patient is dependent. This one says, I see some off-label use of Suboxone 4 to 8 milligrams BID for chronic pain. Do you know of studies about efficacy of this practice?
I do not know of studies that have looked at that.
Okay. This one says, I have a comment regarding the low number of patients that are receiving medication-assisted treatment. Nurse practitioners do not currently have the ability to prescribe buprenorphine. This is a huge problem and contributes to the lack of evidence-based treatment, especially in rural areas. Please continue to advocate for this change. I can tell you that we, the International Nurses Society of Addictions, have been doing that, especially with the TREAT Act that has come out recently. And actually, my medical director commented to me last week that he thinks it is going to go through and we're going to be able to prescribe that. So we all need to write to our legislators, too, to make sure that happens. Carolyn, I don't know if you have any other comments on that.
Nope, I second what you have to say. I think we have been working very hard for many years now, from the very beginning, when they were even looking, when it first came out, and nurses weren't included, and then when they were going to increase the numbers because, they didn't feel that there were enough prescribers, so they needed to increase the number of patients that docs could prescribe for. We also said, hey, you're missing a whole category of potential prescribers. Why don't you just open up, your tight little group here and include some more prescribers? So we have been, I think, working very hard. And yes, I think that if everybody wrote to whoever they possibly could write to, or I know I occasionally get emails saying, support this, support that, support something else. If we all were very careful to follow up on what was going on as far as, policy changes and that type of thing, we have enough numbers. We could impact the decisions that are made. I truly believe that. I think it's just a matter of everybody stepping in and advocating.
Can you comment on the naltrexone implant?
Can I comment on it? No, I can't. I don't know anything about the naltrexone implant.
I can comment, and I'm not sure
Good.
exactly where it is, and others may write in, but I know we had a physician in our state who was in doing a naltrexone implant into subcutaneous tissue, and it was not an FDA-approved treatment, and it would be like a timed release thing that he was manufacturing over like a 3 or 4 month time, and then it would be replaced. I mean, to my knowledge, unless someone can shed light, I've never heard of this being approved.
I didn't know someone was doing that, and I know there
Yeah.
have been enough problems with the injections. So,
Well, it turned out to be a problem for this individual too, because again, it wasn't an approved treatment.
yeah.
Someone's making a comment, says commercial pilots, I believe, cannot be on Suboxone.
Well, I know
Someone's comment.
a lot of the licensing boards do not permit people to resume work when they're on either methadone or Suboxone. I know nurses, I hear that frequently from nurses, that they're not permitted to practice when they're on methadone or Suboxone.
Okay. And this says Suboxone is good for pain. See reports for opiate-induced hyperalgesia. What is your view on making these opioid treatments affordable through a collaborative shared partnership across neighborhood borders by service providers, away from the silo mentality? What does this mean to the impact on those communities and neighborhoods.
I don't know if that individual is in a particular area. I know that my experience from going to different states is that there are certain areas where a state doesn't make treatment providers available, so they cross the state line to another state. I've been in areas where like 3 states abutted, and one state out of the whole group had all of the treatment facilities. So I'm not sure how to answer that question.
Yeah, you may need a little more information with that.
Yeah.
Okay, so I think that's it. I think we've responded to all the questions. I have 8:46 p.m., so we thank you for being here. Carolyn, I thank you for presenting this. Very well done. Also, the recording and the slides will be on the International Nurses Society on Addiction's website, and they should be up tomorrow, so anyone can access the archived recording of the webinar. And they also will be sent to the American Academy of Addictions Psychiatry, who also will be posting it on their website. So you can certainly refer individuals there to listen to it if they couldn't make this evening's webinar. Thank everyone for being here, and we look forward to future webinars as we continue to present in these series. Have a great evening, everyone. We can now end the recording and end the webinar.